So now let's take a really quick look at my reflection on APO scenarios I had during the semester. So to describe the scene, I remember I only had a couple of APO patients actually during scenarios, but I have done it a couple of times with friends and peers outside of scenario work, scheduled scenario work. Both times they were both cardiac causes of APO. Really, one was a cardiac cause, one was not necessarily either, and I'll explain that in a little bit. But they were both quite elderly in the sense that they were lying down for the night, usually wear compression socks, and a lot of peripheral edema and that sort of stuff. So what really might be your typical APO patient. So that's really just a really rough scene setting for you. So feelings. So what were you thinking and feeling? I remember a bit similar to my COPD approach in the sense that, after you arrive and you sit them up and you go through some of your initial approach, you get a history. List of medications is always really important, as it can give some clue into whether it's a cardiac or non-cardiac nature, but I talk about that more in my critical approach. But it's really important, asking those questions, doing your full vital signs survey, and then you got to make it a call, and that can be quite a stressful thing as to, well, am I going to go down the cardiac course of treatment, or can I possibly think of a non-cardiac or almost secondary cause that is making this APO happen? Because we know that we don't want to go down the wrong treatment pathway and exacerbate a problem, or ignore what is actually being the problem, whether it might be an irritated airway, a smoke inhalation, or drowning. I guess, with most of those, there should be a clear mechanism for them to occur, but you still want to be careful. So I remember being a bit nervous about my first scenario going down the GTN treatment pathway, so I definitely remember that at the time. But certainly now feel a lot more confident because I have developed my critical thinking model towards APO that I believe is quite extensive and quite unique. So evaluation, what was good and bad about the experience? Really good in one sense, in that both times especially the first time, I was able to recognize that it was cardiac cause, and that there was a definite cardiac based reason. It was LVF, so left ventricular failure, which was obviously notable on the rhythm strip in the ECG monitor. So I went down the GTN pathway because we want to reduce that backlog of fluid. So it was really good, and able to give the GTN. I did only give the patch because their blood pressure was 100, and plus the fact that they are quite elderly. So if their BP was above 110, I would have given them maybe just the 300 mics, just half a tablet and half the dose to be conservative. So I did give the patch, so that was really good. Also gave them aspirin because generic chest pain we can give aspirin for. But of course, in that same scenario, one thing I did not do very well was, in fact, this was the second scenario. I did give GTN and went down that pathway, and it wasn't necessarily a cardiac cause, so I wasn't able to fully distinguish the two. And the tutor said, I can't remember who it was now, but the tutor did say it was quite a tricky scenario, because I did end up giving GTN and treating that, but also, which wasn't necessarily wrong, because there was no clear cardiac cause, but there was no other non-cardiac cause that I could come up with during the scenario. It was quite a tricky one. But what was bad about it was the fact that I went down the treating the wheeze pathway. So yes, they did have the crackles, but they also had a mild expiratory wheeze. So my brain went into thinking, all right, well, wheeze, we want to treat that. Let's give them some salbutamol. Let's try and fix that. They might be, a mild wheeze, so we're just going to give them the 10 milligrams of salbutamol, which obviously now I know, after further research and really making that bad experience, was that we do not treat a wheeze with APO because it's going to make the problem worse based on the pathophysiology. So, that was was bad at the time, but because I made that mistake, I know I'm clearly not going to make that again, and it's very clear in my mind that we do not treat it in the case of APO because we don't want to make it worse. So what sense can you make of the situation? So that's really looking at the pathophysiology of APO. If you have a look at my domain knowledge section, I have a clear video explaining what is, at a basic alveolar level, what APO is. And so it's a really good video, so please have a look at it if you have the time. Yeah, so making a sense of what's going on with this patient's body, which I always like to try and do during scenarios, or I should have a pretty good pre-existing idea, but try and think specifically what's happening with this patient right now, and that's really going to affect your management and your treatment going forward. What else could I have done? Definitely not treat with salbutamol for the wheeze, which I now know that we don't do. Also, I got the patient sitting upright both times, which was great. I guess could have been a lot more confident in making the call whether it was cardiac or non-cardiac. And once you've made that call, stick with it unless you have a blaring reason not to. That's what you're treating for. So be confident in the decision you make and reassess. And if it's the wrong decision that you've made, then go back and make the right one or find the next best decision, because that's all as a paramedic that we can do is treat what we think is right at the time. If it arose again, would pretty much do very, very similar. Treat the patient with respect, because a lot of the time they might be elderly in their 90, in bed. So can be a very tender situation, which was the couple of times I had it. So would definitely be more conscious of that, and positioning very important, obviously sitting them upright, but also more reassessment of their breathing sounds. So I remember in both times I did it, and then went based off that and diagnosed the APO, but didn't reassess for I think it was 7 minutes or something like that once I had set them up. So I think at least maximum 5 minutes should be reassessing not only their breath sounds but also their entire respiratory status assessment, and just see if, just based on sitting them up or basic management that you do, are they improving. So I would definitely reassess, and I think that should really go across all my scenarios, is that I do need to reassess more, because often I'll arrive at the correct or most correct treatment method, but don't actually reassess to see if the reason I was treating was actually being benefited. So giving GTN, has their blood pressure dropped? Well, I won't know unless I take another blood pressure. So that sort of thing, really basic, but something that's really important. And I've now drilled into my just generic approach to all cases and scenarios. So yeah, I guess this is my last reflection, so I can say I've definitely developed some pretty unique approaches to managing respiratory conditions. Obviously, there are things like manual airway clearance and pediatric respiratory emergencies that I could go down and make an approach for. I do have an approach. I don't think it's overly complex. With the back blows, the chest thrust, it really is just very, very similar to Ambulance Victoria, so I'm not going to bother making my own approach for that. But I will cover that in the clinical skills section, so please have a look. And yeah, I can honestly say I've learned a lot from this unit, and thank you for watching my reflection and critical approach.